The poster session, let's start off in neurology papers. Okay. The first and Jampani Meghana. Madam, are you online? Meghana. Dr. Meghana. Dr. Meghana.
Yes, sir. She is coming, sir.
Sir, my network చాలా తక్కువ ఉంది సార్.
Name chain. Dr. Meghana. అది చూపిస్తావా?
Dr. Meghana, abstract number 11.
So she didn't get the new link, so she will join after some time.
Okay, no problem.
Venkat Pramod Reddy.
Dr.
Sir, she is
Reddy.
coming.
Yes, sir, I am online.
You are online, Dr. Pramod Reddy. You are from which college? Narayana College, Nellore, right?
SV Medical College, Tirupati.
Sri
Venkateshwara Medical College, Tirupati.
Yes, SIMS Tirupati. A rare case of CNS disorder, your Lafora disease. He is your poster, right?
Yes, sir.
Okay. Why did you suspect Lafora disease?
Because the patient is adolescent age,
Yes.
presented with myoclonic jerks.
Yes.
Firstly presented with GTCS, then multiple variant of seizures, sir. Tonic.
Yes.
And
How
myoclonic
about the pedigree chart?
His family members are not involved, sir. It is autosomal recessive.
Not involved at all.
Yes, sir. Generations may be.
Autosomal recessive.
But, yes.
Okay. So sporadic case.
Yes.
Any specific treatment line?
No specific. Only by anti-epileptics we treated, sir. But Lafora disease has a poor prognosis. The patient will die by early 20s. I
so
follow up the case. The patient also died 1 year after admissions.
Okay. Psychiatric manifestations are also common.
Yes,
right?
Sir.
Okay. Thank you for bringing up a rare case. Thank you very much, Dr. Reddy.
Good afternoon.
Please log out. Okay, next. May I know your name?
This is Meghna Jampani, sir.
Meghana.
Meghana.
Okay. Doctor, you are from Narayana Medical College, Nellore, right?
Yes, sir. Yes, sir.
You have reported a case of chorea, hyperglycemic basal ganglia syndrome, right?
Yes, sir. Yes, sir.
Supposing I pick up a textbook and look for cause of chorea, hyperglycemia is not there. Unda?
Rare cause, sir.
Untada?
It's a rare cause, sir.
అదే అంటున్నాను మనం మా టెక్స్ట్ బుక్ లో ఎక్కడ మెన్షన్ చేయరు ఒకటి రెండు డయాబెటిక్ న్యూరలాజికల్ కాంప్లికేషన్ డయాబెటిస్ వెలిటెస్ టెక్స్ట్ బుక్ తీసి చూస్తాను ఎక్కడ మెన్షన్ చేస్తారు కొరియా అని
No, sir.
చేయడు అవునా
Yes.
సో రెండు చోట్ల లేని కొరియాని నువ్వు ఎలాగా సస్పెక్ట్ చేసావు రిలేటెడ్ హైపర్గ్లైసీమియా అని
Sir, after controlling the blood sugars, the movements got controlled, sir.
Good. So there is a cause and effect relationship, right?
Yes, sir.
Hyperglycemia, coliform movements, right?
Yes, sir. Yes, sir.
And the hyperglycemic character coliform disappeared, not because of some other drug. Okay?
Yes, sir. Yes.
Right. Korea, okay. Only coliform movements or any epileptic movements, choreoarthrosis like that? No.
Hemipallismus was
choreoarthrotic
also
movement.
there, sir.
Good. Very good.
Mostly.
So
yes.
you did not mention that in the poster, right? Hemipallismus.
But mostly chorea only, sir.
Okay, Mark. Thank you again for telling us something about a rare presentation of hyperglycemia. Right. Thank you.
sir.
Thank you very much. Meghna, please log out.
Yes, sir. Yes.
Dr. Niharika.
Sir, good afternoon, sir.
Good afternoon, Niharika. Hope
Sir.
you had a nice lunch.
Yes, sir.
Shava?
Yes, sir.
Very good. The case reports of anti-NMDAR encephalitis.
Yes,
Okay.
sir.
What is NMDAR?
NMDAR is a receptor, sir. It's a N-methyl D aspartate, sir.
Okay, very good.
Aspartate receptor, sir.
Good. So this receptor encephalitis and antibodies against this receptor.
Yes, sir.
Okay. Right. How do you confirm it?
We confirmed it on CSF examination, sir. We found the CSF IgG and IgM antibodies in the against NMDR, sir.
Oh, that clinched the whole scenario.
Yes, sir.
Okay. But generally thought of as encephalitis, right?
Yes, sir.
Or psychiatric disorder.
It presented with a psychiatric complaint, sir. Hallucinations, delusions. She presented with complaints of psychiatric manifestations, sir. With and epilepsy, seizures also she had, sir. Generalized tonic-clonic seizures. Based on the age of presentation and female predisposition and clinical manifestations, we suspected it, sir. And radiologically, we couldn't find anything, sir. Normal only, sir.
Is she a pregnant lady?
Yes, sir. She was a pregnant
lady.
Yes, sir.
Pregnant lady. Okay,
Yes,
okay.
sir.
Okay. Right, right. Let's say the clinching point is anti-NMDR receptors. I mean,
Yes, sir.
antibodies.
Antibodies, sir.
The CSF. Good.
Yes, sir.
Nice case report. Thank
Okay.
you.
Thank you, sir.
Next is Dr. Haripriya.
Sir, good afternoon, sir.
Good afternoon, Haripriya. You are from Karnool Medical College.
Yes, sir.
A rare case of monomelic hemiatrophy, right?
Yes,
Monomelic means only one limb is involved.
yes, sir.
Or two limbs are involved.
One limb, sir.
Only one limb is involved. Hemiatrophy means there is muscular atrophy is there. No sensory
Yes, sir.
involvement, no other, nothing. Okay, right.
No, sir. Yes, sir.
Reason is which is made out by MRI cervical spine. Am I right?
Yes, sir. Yes, sir.
What did it show?
MRI showed posterior dural sac was displaced anteriorly, sir. Which during flexion of the neck, sir.
Yeah,
resulting in laminodural.
When I was looking at your posted the photograph of MRI, I thought, why can't I call it a compressive myelopathy?
Sir, usually compressive myelopathy should also have spasticity, sir.
Okay,
science.
supposing I said it's a compression of the root, not the card.
Compression of the
compressive
root.
radiculopathy.
They usually present with pain, sir, but our patient did not have any
compressor of motor root, motor radiculopathy.
The patient did not have any pain, sir. It was gradual in onset, sir. Not acute, sir. It was very gradual in onset.
Motor radiculopathy, chronic, slowly progressing motor radiculopathy.
Sir.
No, because I mean there is something in the spine, right? That's why can't this be that? Why can't I say it is a compressive radiculopathy? That's what I was wondering yesterday. Okay, right, madam. It's nice to bring out a rare case which you commonly don't see. Well suspected, well diagnosed. Thank you. Thank you very much.
Thank you, sir.
Log out. Next candidate is Dr. Ram Manindra Chaudhary.
Yes, sir.
You are online? Okay,
yes,
ma. You are from Narayan Medical College, Nellore. And your poster is about the metachromatic leukodystrophy, right? Okay. What is the clinical presentation like? You said it's almost like a psychiatric disorder, right?
Yes, sir. Behavioral present with a disturbance of the main complaint, sir, for the patient. And
so,
and
when should I suspect? Suppose I get a case of psychiatric disorder. When should I suspect something like this?
If they have any peripheral neuropathies,
Hmm.
or
Hmm.
any type of neuropathies, myelopathies, like that.
So
Because
organic.
both CNS
So,
and PNS, the
Right.
spectrum of disease is very vague, very diffuse, sir.
So
Sometimes
if
they
there,
may present like GBS or CIDP,
Hmm. So
but
if
in
there's an organic neurological
both are not there, sir.
sign, organic neurological involvement, right? Whether neuropathy, myelopathy, whatever it is, right? Huh? Then I would suspect. Any other warning that this should be evaluated? No.
Sir, I didn't get it.
Okay, right. So psychiatric disorder with a neurologically demonstrable neurological abnormality. Right? Suspect this leukodystrophy. Thank you very much for bringing a nice poster.
Thank you, sir.
Next poster is Dr. Arun. Dr. Arun.
Good afternoon, sir.
Dr. Arun.
Good afternoon, sir.
You are from Tirupati SU College,
SU
right?
Medical College, sir.
Pituitary macroadenoma presenting as left hemiparesis. I have seen your
Yes, sir.
poster. Good. But what is the endocrine status? Other endocrine status?
Patient is already a known case of hypothyroidism on treatment, sir.
Okay. Other
And
endocrine
other,
status?
Adrenals are not involved, sir, clinically.
Okay.
And serum cortisol level was also within normal limits, sir. Other, apart from thyroid, all other glands were normally clinically, sir.
No, bit unusual, no, because the macroadenoma generally destroys all other troughs, right?
Yes,
Whether
sir.
they are somatotrophes or thyrotrophs or whatever it is, corticotrophs,
Yes,
all
sir.
cells are destroyed. Right?
But actually,
But,
investigation-wise, all hormone levels we didn't assess, sir, actually.
So
Only
you have,
cortisol level only assessed, sir. Yes, sir.
so you have looked for them, but you could not get
Yes, sir.
any
Patient was
information.
financially was not affordable, sir, for that. So
Okay, ma. So macroadenoma, rarely microadenomas we do see. Macroadenoma generally they don't come to us, but even then you picked up a case, good, because it's present as left hemiparesis.
Yes,
Okay?
sir. Actually, we can consider like a vascular cause, but the CT brain was normal,
Yes.
and MRI done was
Yes.
showing pituitary macroadenoma.
Now, supposing I'll ask a simple question. Supposing you don't have any access to radiological imaging,
Okay, sir.
then what would you have done? Em chesundevvaru meeru?
An ophthalmological visual field evaluation can be done, sir, for that.
Fantastic. Good, Arun. You're reading, right? Good. Thank you.
Thanks.
Then Dr. Anil Kumar from Pinamil Siddhartha.
Good afternoon, sir.
Dr. Anil Kumar from Pinamil Siddhartha. Your
Good afternoon,
poster is on Marchia. Good afternoon. It's your poster is on Marchia 5 bignomy, right?
Yes, sir. Yes,
Corpus callosal involvement in alcoholics, right?
yes, sir. Chronic. Yes, sir.
In this patient, the only clue is alcoholism to say it's the Marchia 5 bignomy. Otherwise, basically
Yes, sir.
corpus callosum involvement, right?
Yes, sir. Yes, sir.
Are there any other reasons for corpus callosum involvement?
Sir,
Other reasons for corpus callosum involvement?
in this case,
Not in this case. Here you said it's alcoholism. But
Yes,
some,
sir.
are there any other etiologies for corpus callosal involvement?
malnutrition, chronic malnutrition,
Okay.
chronic alcoholism,
Hmm.
vitamin deficiency.
Okay, right. Right. Thank you. That's a nice poster. Thank you very much. But make it smaller ones. Okay. Right. Thank you.
Yes, sir. Thank you, sir.
Thank you. Dr. Sai Teja. Dr. Sai Teja
Sir, good afternoon, sir.
from Narayana Medical College, Nellore.
Yes,
Your
sir, yes,
poster is on neuromyelitis optica with
Yes, sir.
anti-aquaporin P4 antibodies which are positive.
Yes, sir.
Hmm?
Yes, sir. Yes, sir.
In this case, you made a clinical diagnosis or after the antibodies came positive?
After the antibodies came positive, sir.
Why? Clinically, it's the patient has got involvement of the optic nerves,
And spinal cord,
symptomatology, and the patient has got involvement of his or quadriceps, I believe, right?
yes, sir.
Huh?
Yes, sir.
Then that should give you a clue. Am I dealing with an MO? Before the antibodies, you should be sort of suspected
Yes.
it. Yes.
Yes, sir.
Okay. Not after MRI, not after antibody. Clinically, you should be able to suspect. But be frank, have you suspected clinically? Have you
Yes, sir.
suspected
Yes, sir.
an MO clinically before
Yes, sir, sir.
MRI, before
Yes, sir.
antibodies? You have suspected it?
Yes, sir. Suspected,
Good.
sir.
Good. Then very good.
Well,
Very good.
both the optic nerves, sir. And spinal
Yes.
cord.
Okay. Supposing I say retrobulbar neuritis and then paraparesis. What else will you think of? Multiple sclerosis, right?
Yes, sir. Multiple, sir.
How do you rule out?
Clinically, sir.
Clinically. Okay, for investigation wise,
Investigation
rule out?
in the MRI spinal cord, sir, more than 3 segments. are
MRI.
involved.
MRI is a suggestion of not a demyelination, but more of what is that? T1 hypointense, T2 hyperintense, thickening of the cervical spinal cord. Am I right?
Yes, sir.
That gives the clue. It's a radiological diagnosis there. Okay, Bob. Okay, Babu. Thank you. Thank you very much for giving us a good poster.
Thank you, sir.
Then Dr. Anurag
Yes, sir.
from Narayana Medical College, Nellore.
Yes, sir. Good afternoon, sir.
The problem is that I could not get a video of your poster in my laptop. It's not available. So can you tell me briefly, right? In 1 minute, how about your poster?
Sir, it is a cerebellar syndrome, a late complication of phenytoin toxicity, sir. She came with the history of she had a suicidal for the consumption of phenytoin tablets, sir, about 40 tablets. 20 days back, sir. At that time, she gastric lavage went on, all the symptomatic treatment was given, sir, and she was discharged. But after 20 days, she presented with the cerebellar symptoms, sir, unsteadiness and swaying while walking, this and all she presented.
Yeah, unusual, because acute toxicity we see this gait ataxia, but
Yes,
late occurrence after becoming normal, late occurrence is unusual. Right, that's why you brought out this case, late
Yes.
occurrence. Has it been reported? Has it been reported in literature? Late complication.
Yes, sir. Unusual, sir. It was in the literature, sir.
Literature, reported literature.
Yes, sir.
Okay. Right. So unusual complication.
Unusual complication, sir. Generally, we will see as acute complication, but it is
yes. Late complication. Right. Thank you. Thanks for bringing us a nice poster. Thank you, Babu.
Thank you, sir.
Then Susmita Jaya Sindhu, madam,
Sir.
from Narayan College and Hospital, Nellore.
Good afternoon, sir.
Good afternoon, madam. No, you're talking about no. You'll be talking about hyperhomocysteemia in Moya disease. Cause or association? Wow, that's the question. Who will answer the question? Myself or yourself?
Sir.
You said you have put up a question mark. Cause or association? What is your answer for that question?
Hyperhomocysteemia, it is as a cause or association. It is presenting in the its association with hemorrhagic stroke or Moya disease is not known, sir, in the literature.
Yes. So, the question is, can we answer like this? I can say that homocysteemia has caused occlusion of this vessel slowly with the development of collaterals, Moya, right? That's
Yes,
one
sir.
way of explaining. So, homocysteemia is the cause of Moya.
Yes, sir.
Okay, or this can be a rare case where there is moya congenital anomaly along with hyperhomocystinemia.
Yes, sir.
Which will you vote for?
Cause it
Huh?
might be the cause of moya disease.
Might be a cause of moya. Okay, right. But hyperhomocystinemia resulting in vascular occlusions to the brain only, without any effect on the cardiac vessels, on the peripheral vessels. Well, to be taken with a pinch of salt. So probably it's only a rare association of homocystinemia and Moyamoya disease, right? Okay.
Yes. Okay, sir.
Thank you, madam, for bringing us a good poster. Thank you.
Thank you, sir.
Next, Dr. Sai Sumant.
Yes, I'm present, sir. Good afternoon, sir. Hello, sir. Hello, sir.
Hello. Okay, you on a rare case of stroke in young, again about Moyamoya disease, right? Okay.
Yes, sir.
Right. How could you confirm the Moyamoya disease? By
it was
going
through
for an angiogram.
Yes, sir. It was through MR angiogram, sir.
Okay. In this patient, did you palpate the carotids?
Yes, sir.
They're intact or abnormal?
Sir, intact, sir. On right side, there was a little diminished flow, sir.
Where
one
was
side.
little? Did you hear? Did you look for bruit over the carotids?
Yes, sir. But there was no bruit, sir.
No bruit. How about the peripheral vessels?
Peripheral vessels were intact, sir. Normal, sir.
Any evidence of ischemic heart disease?
No, sir. No such evidence was found, sir.
No. So it's not a generalized vascular involvement. So
No,
only
sir.
only
Central
limited to
CNS
the
was
base of the brain.
Yes, sir. Yes, sir. It
Okay.
was a
No
kind of
bruise, nothing.
basal moya, sir.
No bruise, nothing. Okay.
No, sir.
All right. So diagnosed only with MR angiogram, right?
Yes, sir.
Okay, MR, right. Thank you for bringing us a nice rare case. Thank you.
Thank you, sir. Thanks, sir.
Then Dr. Dharma Sai.
Yes, sir. Good afternoon, sir.
Good afternoon.
Good afternoon, sir.
From Venkateswara Medical College, Tirupati.
Yes, yes, sir.
Second year postgraduate or final year postgraduate?
Second year, sir.
What is Garcin syndrome?
Sir, it's a rare syndrome involving only the cranial nerve palsy, sir, without involving long tract motor and sensory involvement, sir.
Only one side or both sides?
Only unilateral progressive palsy.
Unilateral. That's important, right? Only unilateral. All are element palsies or human palsies?
Yes, sir. All are element type of palsies.
All are element palsies. Okay?
Yes, sir.
Right.
Yes, sir.
So what are the nerves involved in your patient? You made a list, I believe.
Except
right?
1, 2. Yes, sir. Except 1, 2 and 11 and 12, sir. More than 7 nerves are involved, sir.
Involved, right?
Yes, sir.
Okay.
Yes, sir.
So 1, 3, 4, 6. All three are involved.
Yes, sir. 3, 4, 6 are involved, sir.
What is the clinical presentation? If 3, 4, 6 are involved, what happens to the eyeball?
Yes, sir. Toes is present, sir, and all movements are completely restricted, sir. Extraocular movements are completely restricted, sir.
Eyeball is immobile.
Yes, sir. Completely movements are restricted, sir. Pupils are mid-dilated, not reactive to light, sir. Direct light reflex, consensual light reflex, and accommodation reflex are absent, sir.
Okay, right. So 3, 4, 6 complete involved. Total ophthalmoplegia, that's what we call it. Both internal and external ophthalmoplegia. Total ophthalmoplegia.
Total, yes, sir.
Very good, very good, very good. Nice case. Right? Thank you very much for presenting as a poster. Very nice case.
Yes. Thank you so much.
Dr. Lokesh.
Sir, good afternoon, sir.
You're from again Tirupati Medical College,
Yes,
Medical College.
Yes, sir.
Right. A neurodegeneration with a brain iron accumulation.
Yes,
right?
sir.
Okay.
Yes, sir.
I mean, old timers like me.
Sir,
Hello, what is disease?
Sir,
Hello,
sir,
Lokesh.
your connection is not. Sir, your connection is poor, sir.
What can I do? Hello, Lokesh, am I audible?
Yes, sir. Now it's audible.
audible.
Audible. Okay. All right. Neurodegeneration is brain iron accumulation, right?
Yes, sir. Yes, sir.
Is it different from hemochromatosis?
Yes, sir. In this patient, I examined KF ring also is not found, and serum ceruloplasmin is normal, sir, in this patient.
I'm talking about hemochromatosis.
Liver involvement is not there, sir, in this patient.
How could you confirm?
Liver function tests are normal, sir.
What is, suppose there is hemochromatosis, we call it a bronze diabetes, pigmentation, diabetes mellitus,
Yes, sir.
testicular atrophy. ఇవేమైనా ఉన్నాయా వీళ్ళు?
ఏం లేవు సార్.
లేవు, చూసావా? సో ఎప్పుడు లేవని చెప్పేస్తున్నావా?
చూసాను సార్.
చూసావు. సో you ruled out hemochromatosis.
Yes, sir. Hemochromatosis and Wilson's also I ruled out, sir.
Ruled out. Okay, very good.
Yes, sir.
Okay, right. So brain Holoverton Sparks disease.
Yes,
That
sir.
used to be our diagnosis in maybe a decade ago. Okay,
Yes,
right.
yes, sir.
Thank you very much.
Thank you.
Dilip, Dr. Dilip.
Sir, yes, sir. Good afternoon, sir.
TBM as a syndrome of SADH
Yes,
and
sir.
obstructive hydrocephalus.
Yes, sir.
So two complications of TBM.
Yes, sir. Yes, sir.
Right? How could
Yes,
you
sir.
confirm that? How could you confirm the TBM? How have
Sir,
you confirmed the TBM?
Sir, by CSF
TBM.
analysis, on CSF analysis, it's positive for Mycobacterium tuberculosis by CBNAT method, sir.
Very good. So confirmed TBM.
Yes, sir.
How did you confirm CAD?
Sir, by checking the urine osmolality and urine sodium excretion, sir, it's around
Fantastic.
27.
Sodium
27
levels. Sodium levels.
In serum, it's around 127, sir. Moderate hyponatremia is there, sir.
Good. How could you make out obstructive hydrocephalus?
Sir, initially we done CT and later we done MRI, sir. It's it's showing obstructive pattern, sir, and with
Okay.
enhancing systems in the cerebellum, sir.
Right. I'll ask you just one more question. Did you look
Yes,
at
sir.
the fundus?
Sir, fundus, yes, sir.
What is the finding on fundus?
Sir, it's like papilledema is there, sir. No choroidal tuberculosis are there.
Did you mention it in the paper?
Paper?
Papilledema.
No, sir.
Why?
Fundus I didn't mention, sir.
Mention cheyal babu.
Yes,
Because you're
yes,
talking about obstructive hydrocephalus. You should look at the fundus and you should mention it. Okay? Right. Thank you. Thank you very much. Next, Dr. Gayatri.
Good afternoon, sir.
Good afternoon, Gayatri madam. You are from again Venkateswara Medical College, Tirupati.
Yes,
So
sir.
many people from that college. I think you should have a very active department of neurology there. Right.
sir.
Tuberous sclerosis presented with status epilepticus
Yes, sir.
and aspiration pneumonia. Okay.
Yes, sir. Yes, sir. Patient presented with generalized tonic-clonic type of seizure, sir.
Okay. Right. Seizures can lead to aspiration pneumonia. There's no doubt about it. Right?
Yes, sir. Yes, sir.
Aspiration pneumonia is because of oropharyngeal flora or something else?
No, sir. Patient was unconscious since 4 days before the admission, sir.
I'm not talking about this patient. In aspiration pneumonia, right? The pneumonia is because of oropharyngeal bacteria or something else.
So patient has given some native medication while the patient was unconscious.
No,
sir.
I'm not, Gayatri Garu. I'm not talking about this patient. Right? A patient had an epileptic fit. He has aspirated. He developed a pneumonia. Pneumonia is because of what?
Because of upper airway oropharyngeal microbial flora, sir.
Because of
Hello, sir.
What is Mendelssohn syndrome?
Hello, sir. Not
Syndrome.
audible, sir. Hello.
Not audible. Hello.
Hello, sir.
అమ్మా నువ్వు వినపడుతుంది, నువ్వు చెప్పి అడిగింది నేను అడిగింది
Sir.
వినపడుతుందో తెలియదు మరి.
సార్ ఇప్పుడు వినిపిస్తుంది సార్.
వినిపిస్తుందా?
ఇందాక వినిపించలేదు.
అమ్మా మెండెల్సన్ సిండ్రోమ్ అంటే ఏమిటి? అంటే ఆస్పిరేషన్ ఆఫ్ యాసిడ్ కంటెంట్స్ మూలంగా కెమికల్ న్యూమోనియా వచ్చిందా? ఆస్పిరేషన్ ఆఫ్ బ్యాక్టీరియల్ ఫ్లోరా మూలంగా ఇన్ఫెక్టివ్ న్యూమోనియా వచ్చిందా?
సార్ ఆస్పిరేషన్ ఆఫ్ యాసిడ్ కంటెంట్స్.
దాని మూలంగా వస్తే మెండెల్సన్ సిండ్రోమ్ అంటాం. అది వచ్చిందంటావు ఇప్పుడు ఈ పేషెంట్ లో, అవునా?
సార్
యాసిడ్ ఎందుకు వస్తుంది నోట్లోకి?
సార్ డ్యూ టు the pharyngeal muscles, depression of the neurological depression, sir. The pharyngeal muscles.
There is a tonic and then chronic contraction of abdominal muscles. అవునా? దానివల్ల ఇంట్రాబ్డోమినల్ ప్రెషర్ ఏమైపోతుంది?
Increased, sir.
అమ్మో, వెరీ గుడ్, రైట్. సో అబ్డామినల్ స్టమక్ లో కంటెంట్స్ ఏమవుతాయి? వెనక్కి వస్తాయి థ్రోట్ లోకి, అవునా? తర్వాత పేషెంట్ is semi-conscious. He aspirates those acidic contents, right? Regurgitated acidic contents are aspirated. Okay, right.
Okay.
Right. You are in which year?
Second year, sir.
Second year. బాగా నేర్చుకో తల్లి. Thank you very much.
Okay, thank you.
Dr. Lingappa. Dr. Lingappa.
Abstract number 106, Dr. Lingappa.
From Kurnool Medical College, Dr. Lingappa. Not available?
Okay, sir. Maybe he not, sir.
Okay.
Shashikumar Raju.
Dr. Shashikumar Raju.
Padmaraju Shashikumar Raju.
From Kurnool Medical College.
He is also.
Okay.
Dr. Maddal Vamsi Krishna.
Yes, sir.
Okay, sir.
Okay. Your paper, you're from Master College, Eluru.
Yes,
Your
sir.
paper is on posterior reversible encephalopathy syndrome. Is it in a pregnant woman?
Yes, sir. 20-year-old preemie, sir.
Hypertensive.
Yes, sir.
Having proteinuria.
Yes, sir. And
there is edema in the posterior occipital lobes. Okay.
Yes, sir. Yes, sir.
Okay. ఇది ఉంటే ప్రెస్ అన్నాము, అవునా?
ఎస్ సార్.
ట్రీట్మెంట్ ఏం చేశారు?
ఫస్ట్ హైపర్టెన్షన్ మేనేజ్మెంట్ చేసాం సార్. నికార్డిపిన్ పెట్టాం సార్. అండ్ సీజర్స్ కి లివిట్రసెటమ్ పెట్టాం సార్.
ఓకే రైట్. అవసరమా లివిట్రసెటమ్?
యాక్చువల్లీ పేషెంట్ జీటీసీఎస్
అవునమ్మా, ఏం చేయకపోయినా తగ్గిపోతుంది కదా సీజర్స్?
ఎస్ సార్. At that time we thought of giving it.
సో మామూలుగా అయితే అక్కర్లేదు, తగ్గిపోతుంది. హైపర్టెన్షన్ తగ్గించేస్తే తగ్గిపోతుంది. తగ్గకపోతే గో ఫర్ మెగ్నీషియం మ్యాక్సల్. అంతే. ప్రెగ్నెంట్ ఉమెన్ కదా, రకరకాల యాంటీబయాటిక్స్ ఇవ్వకూడదు. ఆల్మోస్ట్ ఆల్ యాంటీఎపిలెప్టిక్స్ ఆర్ contraindicated in a pregnant woman, right? Almost all. You remember it, right?
Okay, sir.
Thank you.
Thank you, sir.
Dr. Venkata Sai Kiran.
Sir, good afternoon, sir.
Yo, Venkata Sai Kiran.
Yes, sir. I am Venkat Sai Kiran, sir.
From NRI Institute of Medical Sciences, Visakhapatnam.
Yes, sir.
Right. Opalski syndrome is cerebellar infarct and ipsilateral. Okay, right. So it's a variant of lateral medullary syndrome. Am I right?
Yes, sir.
So what are the extra features?
Sir, one is hemiparesis, sir. Ipsilateral hemiparesis.
On the same side, yes.
On the same side, sir. That is why we call it as Opalski syndrome. If the lateral medullary syndrome is associated with the contralateral hemiparesis, we call it as Babinski-Nagoudi syndrome.
Okay, right.
Another feature is the ipsilateral upper motor neuron type facial palsy, sir.
One more thing. Okay,
Sir.
right.
So, and the other thing is here Horner syndrome is absent, sir.
మరి బాబు లేటరల్ సిండ్రోమ్ అంటే ఎక్కడ ఉంటుంది? ఇన్ఫీరియర్ కదా, మిడిల్లో కింద ఉంటది.
సార్
ఏమి ఈ సెవెంత్ నర్వ్ న్యూక్లియస్ ఏమో అక్కడ మిడ్ పాయింట్ లెవెల్లో ఉంటుంది.
సార్ ఎస్ సార్.
మరి చాలా దూరం కదా.
సార్ దీనికి హైపోథెసిస్ ఉన్నాయి సార్. బికాజ్ కొన్ని స్టడీస్ చేశారు సార్, ఒక ఫ్యూ స్టడీస్ లో బై యూజింగ్ ట్రాన్స్క్రేనియల్ మ్యాగ్నెటిక్ స్టిమ్యులేషన్ స్టడీస్ సార్. అక్కడ ఏం ఫైండ్ అవుట్ చేశారంటే దట్ ద కార్టికోఫేషియల్ ట్రాక్ సమ్ టైమ్ హ్యాస్ అన్ అబరెంట్ పాత్వే which follows descends down in the ventromedial medulla, decussates and then ascends up in the dorsolateral medulla, sir. Finally reached to the facial nerve nucleus from the below. So in such cases the yes, sir. And this is very rare and not yet proven in biopsy, sir, like in this thing.
ఫైబర్స్ కిందకు వచ్చి మళ్ళీ పైకి వెళ్ళే టైంలో ఇన్వాల్వ్ అవుతాయి అన్నమాట. దాని మూలంగా ఇప్సిలేటర్ UMN సెవెంత్ పాలసీ వస్తుంది.
UMN type, sir.
Right, that's a fantastic explanation. నాకు కొత్త పాయింట్ నేర్పోయేవాడు. థ్యాంక్ యూ వెరీ మచ్.
థ్యాంక్ యూ సార్. థ్యాంక్ యూ.
ఓకే బాబు. వంశీకృష్ణ ఆశ్రమ్, డాక్టర్ వంశీకృష్ణ అయిపోయిందా? అయిపోయింది కదా. ఓకే ఓకే రైట్, కంప్లీటెడ్. ఓకే, డాక్టర్ వికాస్, మెడికల్ కాలేజ్. డాక్టర్ వికాస్.
Hello. Yes, sir. Good afternoon.
Dr. Vikas from RMC Kakinada. Neuromyelitis optica spectrum disorders, right? What are all the disorders which come under this umbrella?
Patient presenting with optic neuritis, acute myelitis, and area post-trema syndrome, and acute brainstem syndrome, and with symptomatic narcolepsy, and with narcolepsy and diencephalitic lesion.
Okay, so this contains about 4 or 5 disorders, right? What is the clinching point in diagnosis?
Serum aquaporin 4 antibody positive, sir.
Serum or CSF?
Sorry, CF, sir.
CSF, not serum, right? Sure?
Yes, sir.
So whenever you have got such a bilateral or unilateral optic involvement, whenever you have got a unexplained brainstem involvement, right? Antena?
Sir. Yes, sir.
Inకేమిటి? Unexplained paraparesis or quadriparesis. Amy, అలాంటప్పుడు kindly think of this possibility also. Other take home message. బాబు.
Okay, sir. Yes, sir.
Take home message అదే కదా కాదా? ఈ కేసు నాకు ఎందుకు అందరికి ఎందుకు చూపిస్తున్నావు అంటే ఈ పోస్టరు unexplained optic nerve involvement, unexplained para or quadriparesis, unexplained what చెప్పాను ఇన్వాల్వ్మెంట్ ఆఫ్ ఇంకేమో వస్తాయి
area post hiccups and vomitings.
అలాంటివి వచ్చినప్పుడు కైండ్లీ థింక్ ఆఫ్ దిస్ పాసిబిలిటీ ఆల్సో. వేరే కారణాలు దొరకకపోతే అని చెప్తావు. యూ గో ఫర్ ఏ CSF aquaporin 4 antibodies. Yes, sir. So that's what you wanted to tell everybody who had a look at your poster.
Yes, sir.
Or poster la మాట రాసావు కింద. Okay, David. Thank you.
Okay, sir.
Anil Kumar.
Sir, Anil Kumar, sir.
You are Anil Kumar? No.
Yes, sir. I am technical issue. Well,
yes, sir. Dr. Anil Kumar.
Sir.
Dr. Anil Kumar, are you online?
Yes, sir. I am online, sir.
Okay, you are from Narayana Medical College, Nellore, right?
Yes, sir. Yes, sir.
Your poster is on transverse myelitis.
Yes, sir. Yes, sir. Transverse myelitis.
Just a minute.
Sir.
Is there any sensory loss in your patient?
Yes, sir. Actually, yeah, sir. Actually, my patient has weakness, tingling, and numbness sensation, sir. in both upper and lower arms, and followed by urinary retention and dysphagia and dyspnea, sir. There is no history of headache, trauma, or neck stiffness, double vision, and deviation of mouth, sir.
You have mentioned them under examination. Loss, sensations lost.
Sir, yes, sir.
Bladder involved.
Yes,
Okay.
sir. Yes, sir.
So there is involvement of bladder, there is involvement of sensory system, sensory loss
Yes,
below
sir.
a particular level. There is a
And
flaccid
motor.
paralysis, motor involvement.
Yes, sir.
Okay, all right.
Yes, sir. Motor
And
involvement, sir. Yes, sir.
and the nerve conduct studies did not show a demyelinating pattern.
No, sir. Actually, aquaporin 4 channel were positive, sir. Antibodies against aquaporin channel.
But what are the
Actually, she has presented a history of
nerve conduct studies? What is the nerve
sir, actually, I have
NCS?
planned MRI spine, sir.
I asked you, right? Nerve
NCS.
conduct studies, have they been done?
No, sir.
No. Okay.
Actually, I have planned MRI spine, sir. It showed hyper intensity from C2 to C6 level, sir. Extending over 3
అనే
or
ఉంది
3
అని కాదని
vertebra,
అంటలేదు.
sir.
నువ్వు చేసావు, నేను కాదంటలేదు. నువ్వు మామూలుగా అనుకో, నేనేం ఆలోచిస్తాను, డిమైలినేషన్ ఏమైనా వచ్చిందేమో అని అనుకుంటాను. అవునా ఏంటి?
Yes, sir. One of the possibilities multiple sclerosis.
నర్వ్ కండక్షన్ చేసుకుంటాను.
Nerve
నర్వ్
conduction.
కండక్షన్
Yes.
చేసుకుంటాను.
Yes, sir.
మరి అది చేయకుండా నువ్వు ఎంఆర్ఐకి ఎందుకు వెళ్ళావు?
Sir.
సార్ ఈసారి అలా చేయకండి సార్. ఏమి ఏంటి, ఒక్కొక్క స్టెప్ లో వెళ్ళాలి. తలనొప్పితో రాగానే సిటీ బ్రెయిన్, పారాలసిస్ తో రాగానే ఎంఆర్ఐ అలా చేసేయకూడదు. థింక్ థింక్ థింక్. ఓకే
Sir.
ఓకే బాబు, థ్యాంక్ యూ.
Sir. Thank you, sir.
నెక్స్ట్, థ్యాంక్ యూ బాబు. డాక్టర్ మానస.
Yes, sir. Good afternoon, sir.
Good afternoon, Dr. Manasa. Here I am a disease, a variant of motor neuron disease, right?
Yes, sir. Yes, sir.
Briefly tell me about this disease. Very brief.
Yes, sir. It is a rare variant of motor neuron disease. It has male predominance and it is associated with monomelic amyotrophy. And more common in Asian ethnicity. It is with a self-limited course, sir. Mostly distal muscles are involved, sir. Upper limb muscles. Element type of distal muscle atrophy, sir.
Okay. MRI cervical spine?
MRI cervical spine, flexion MRI is most useful, sir. In flexion MRI from the C7 to T1 level, there is anterior pushing of the posterior dura and posterior epidural crescent appears very hyperintense, sir.
What is the reason for the crescent?
Is due to repeated extension of the neck in some patients due to unequal growth of the spinal cord and the vertebra. The posterior descent actually slack of the dura is not maintained, sir. The dura is actually slack and it is turned into folds. In this disease, during neck extension, this slack of dura cannot be maintained and it is extended. So posterior dura it is pushed anteriorly, sir. This results in engorged venous plexus. This engorged venous plexus results in compression over the ischemic changes, sir. Ischemic changes of the anterior horn cells. This results in element types, sir.
So, dural redundancy, right?
Yes, yes, sir.
Followed by proliferation of venous plexus.
Yes,
right?
sir.
Followed
Yes,
by venous infarct of the antihorn cells.
Yes, sir.
ఏమా అంతేనా?
Yes, sir.
మరి మోటార్ న్యూరోన్ డిసీజ్ కి దీనికి సంబంధం ఏంటి?
Motor neuron disease in ALS also anti-horn cells get involved, sir.
ఇలాంటివి ఉండవు కదా?
No, sir. No, sir. No venous congestion, nothing, sir.
ఓకే, అంతేనా?
Okay.
ఇలాంటివి
Yes,
ఉండవు.
sir. Yes, sir.
రైట్, థ్యాంక్ యూ.
Yes,
థ్యాంక్ యూ.
Thank you, sir. Thank you.
డాక్టర్ సాగర్, Pannada Sagar from Kurnool Medical College. Dr. Sagar from Kurnool Medical College. Dr. Sagar.
Sir, maybe Dr. Sagar. Sir, maybe he is not online. I'll
Okay,
call him.
right.
Sai Venkat Konakanchi.
Yes, sir.
Sai
Good afternoon,
Venkat.
sir. Good afternoon, sir. Sai Venkat,
From
sir.
yes, from permanent name Pinamel Siddhartha.
Yes,
Okay,
sir.
prayer presentation thymoma in a young male, right?
Yes, yes, sir.
What is the rarity? Commonly we talk about myasthenia gravis,
Yes, sir.
right?
More
What is the
than one.
rarity
Yes, sir.
in
First
this
of all,
in this patient? You said there is hypoglycemia, right?
yes,
There
yes,
is
sir.
paroxysmal hypertension,
Yes, sir.
paroxysmal hypoglycemia,
Yes,
right?
sir.
And paroxysmal sympathetic stimulation,
Yes, sir.
sweating, right? Okay.
Yes, sir. Yes, sir.
Is it only thymoma or is there any neuroendocrine tumor associated?
Actually, we suspected, sir, the neuroendocrine paraneoplastic syndrome involving pituitary and cerebellum, sir. But it was not when based on the chemical profile, sir.
Can a neuroendocrine tumor cause hypoglycemia?
Yes, sir.
Hypertension?
Non-insulinoma.
Yes.
Sir.
That can
Non-insulinoma
also,
type of tumor. Yes, sir.
so you ruled out a pancreatic tumors?
Yes, sir. What we
Huh?
did was screening. The screening CCT was done for abdomen, sir. It showed no likely tumors originating from pancreas and any gastric tumor.
How do you rule out a pancreatic tumor? Is it enough if you just go for MRI?
No, sir.
You have
Fasting.
to go.
What we do is fasting insulin and the C-peptide, sir.
Is there something like a radioisotope scan to rule out pancreatic tumors? Some MIBG scan, something like that? ఏదో వేగ్గా గుర్తుంది నాకు అలాంటివేవో చేయాలి అని చెప్పి pancreatic tumors కి, particularly if you want to rule out an insulinoma.
Initially, what we checked for was C-peptide and fasting insulin, sir, because the both are within normal limits. We 90% rule out.
Both are elevated, non-elevated in your case.
C-peptide was within
normal limits.
Yes, sir. C-peptide was within normal limits, sir. Fasting insulin was 26. Cutoff was 25, sir. It was 26 in our response.
Okay. Have you heard of insulin-like peptides?
Yes, sir.
Maybe they are getting generated, insulin proper.
Sorry, sir.
No, because hypoglycemia can hyperinsulinemia or elevated levels of secretion of insulin-like peptides can cause hypoglycemia, can cause as a reflex hypertension, right? Tachycardia, sweating.
Yes, sir. Reflex hypertension was recorded, sir, but in the outpatient it was hypotension, sir. And what we thought was yes, sir. What we thought was when the tumor is active in active form, it is causing hypoglycemia.
Okay, right. Basically, it's not suspected. మీకు అనుమానం వచ్చిందా ముందు? పేషెంట్ చూసిన తర్వాత మీకు అనుమానం వచ్చిందా రాలేదా? థైమోమా ఏమో అని.
No, sir. At the time of presentation, it was only seizures, sir, and with the recurrent history of seizures, sir. He was on phenytoin at the time of presentation, sir. And what we observed while examining for liver span, it told tenderness in the chest area, sir. So what we took an ultrasound and X-ray, which revealed the mass originating likely from anterior mediastinum, sir.
Okay, Amma. Right. Thank you for bringing us a rare case. Right. Thank you. Dr. Manusha from Government Medical College, Kadapa.
Good evening, sir.
Dr. Manusha, your case is neuromyelitis optica.
Yes,
right?
sir. Yes, sir.
Presentation with
Area posterior syndrome, sir. Only isolated intractable vomitings and hiccups, sir.
Okay, that's all.
Yes, sir. My case is a 15 years old male, sir. Actually, he presented with a history of 1 month intractable hiccups and vomiting, sir. He had undergone many investigations outside for both local and metabolic causes and was treated as psychogenic vomiting, sir. He presented to me with a weakness also, sir, asymmetrical weakness, sir, with a power of 3/5, sir.
Yes, there are some
in
neurological
paralysis.
signs. Okay.
Yes, sir. Yes, sir.
Right. Okay, Amma. Right. So that's why you thought of another possibility.
Yes, sir.
You got an
Yes, sir.
MRI done. MRI
Yes,
showed
sir.
a T1 hypotenuse, T2 hypotenuse, thickening of the
Yes, sir.
cervical spinal cord. Then you
Yes,
have
sir.
gone for an antibodies. Confirmed.
Yes, sir.
Okay, na?
Also blurring of vision was there, sir. The visual potential was done, sir.
Beyond.
So
Done.
which showed demyelinating features of bilateral optic nerve, sir.
Okay, Amma. Thank you for bringing us a typical case. Thank you.
Thank you, sir.
Dr. Sai Baba. Thank you, Manusha. Dr. Sai Baba from Karnool. Dr. Sai Baba
Dr. Sai Baba.
from Karnool.
Sir, maybe he is not there. We'll take
Okay.
Swapna.
Dr. Swapna.
Good afternoon,
Doctor.
Oh, Dr. Swapna.
Yes, sir.
Okay, you're from Pinman Siddhartha, right?
Yes, sir.
Korea is the first presenting site of rheumatic fever, 11-year-old child.
Yes, sir.
First of all,
Hello.
first I have to congratulate you
Yes, sir.
for seeing a case of sudden hams chorea, because in my 40 years of clinical career, I have not seen a case of sudden hams chorea. Only I read about it. I have not seen a case. Okay, good. You're fortunate. Okay,
Thank you.
but Korea appeared within 2 weeks of the presentation, right?
Yes, sir. Yes, sir. Hello.
Swapna, Dr. Swapna. Dr. Swapna.
Sorry, sir. I got disconnected.
Dr. Swapna, please check your
Yes, sir.
internet connection.
Yes, sir. Hello.
Dr. Swapna. Okay,
Yes, sir. Yes.
I'll go to the next
Sorry, sir.
candidate
Yes.
then. Murthy, Mr. Murthy, I'll go to the
Hello.
next candidate. Dr. Bhagiratha. Dr. Bhagiratha.
Yes, sir. Good evening. Good afternoon, sir.
You're
Hello,
online, sir?
Yes, sir.
You're online. Okay. Your posterior presentation is
Posterior reversible encephalopathy syndrome,
encephalopathy syndrome and late syndrome. Is the patient hypertensive?
Not, sir. Not a known hypertensive, sir. Patient is
Not a
25
known
years.
hypertensive.
Not a known hypertensive, sir. No high recordings are not there in third trimester, sir.
So, what do you think is the reason? What do you think is the reason for this reversible encephalopathy?
But
it's not
on
hypertension,
presentation,
you said.
Yes, sir. Not a known hypertension, sir, but at presentation, her BP recording is high, sir. It is 170/90, sir.
But that's not very high. Okay.
Maybe that may be the reason for the posterior reversible encephalopathy syndrome. I'm thinking.
So basically, it's only an MRI finding, right?
Yes,
only
sir.
MRI finding.
Only MRI findings. Yes.
Okay, only that can be the way to diagnose this case.
Yes, sir. Clinical features like only one episode of GTCS she presented with.
That's all. Only seizures, late postpartum. Generally, we are not 170/90. Generally, we don't suspect a press. But just because of
Yes, so we
MRI showed a
suspect.
different issue.
Yes.
Okay, so we have gone for the diagnosis press. Right, Babu? Thank you.
Yes.
Thank you very much for a nice poster.
Okay,
Then
thank you, sir.
Dr. Ashwan. Thank you, Babu.
Hello. Hello. Hello.
Hello, Dr. Yaswant. Dr.
Sir, good
Yashwant.
afternoon, sir. This is Dr. Yashwant, sir.
Oh yes, you are from
Yes, sir. I'm
Pondicherry.
Dr. Yashwant, sir.
You are from which college?
Yes, sir. I'm from Hyderabad, sir. I'm studying in Vinayaka Mission Medical College at Pondicherry.
Pondicherry, yeah. Okay, you are a final year postgraduate or second year postgraduate?
Yes, sir. Yes, sir. I'm a
Final
final
year
year postgraduate, sir.
So hemiplegic migraine, ganglioma of the parietal lobe mimicking hemiplegic migraine, right? We have heard about gliomas, glioblastomas. What is ganglioglioma?
Sir, ganglioma is also a form of tumor, sir. It's very rare, sir. Only 0.4 to 1%.
Oh, there is a lot of crosstalk. Can you see ganglioma?
Sir, ganglioma, it's a very rare form of cranial tumor, sir. It is like we have done a PubMed search after getting this histopathological diagnosis, and we found that was accounting only for around 0.4 to 1% of the intracranial tumor load. In fact, all Sir, am I audible?
Okay, Dr. Yashwant.
Hello.
Sir,
am I audible, sir?
Dr. Yashwant.
Sir, అది sir.
Now, okay.
So, case histopathological diagnosis అయ్యాక we have done a PubMed search, sir. అయితే
Yes.
Worldwide there were only around 700 to 720 cases reported. దానిలో కూడా almost all the cases were confining to the temporal lobe. There was only one case apart from our case which was confined to parietal lobe.
Okay, right, Babu, right, good. That's a nice presentation of a rare case. But clinical presentation with rare, that's interesting, right? That's interesting because you should have not a paroxysmal pain. Right?
Yes, sir.
That's interesting.
Because clinically what happened is when we looked back hemiplegic migraine, we found to be associated more commonly with cerebellar, sir. So this was a very unusual association of a parietal lobe involvement. So then we went ahead for brain imaging, and then we found it was a tumor inside in the parietal lobe, confining to the parietal lobe. Hello.
Hello.
Sir, am I audible?
Your explanation is satisfactory. I have learned something from you. Thank you very much.
Thank you, sir.
Now, Dr. Pavanteja.
Hello.
Dr. Yashwant, please.
Hello, good afternoon, sir. Hello, good afternoon, sir.
Oh, you're Dr. Pavanteja, yes?
Yes, sir.
Hello.
Hello, sir. Good afternoon,
Am I
sir.
audible?
Am I audible? Yes, sir.
You're audible, and Bhagavan is also reading you. Okay? All right.
Okay, sir.
The presentation, the representation, reversible linear lesions.
Sir, voice is not clear, sir. Hello, sir.
Okay, I'll call the
Sir, మీ వాయిస్ రావట్లేదు.
హలో సార్.
సార్ మేబీ అక్కడ ఇంటర్నెట్ ఇష్యూ అయి ఉంటది, వాయిస్ కరెక్ట్ రావట్లేదు.
వాయిస్ రావటం లేదు.
హలో సార్. సార్ వినిపిస్తుంది సార్, కానీ క్లారిటీ లేదు.
క్లారిటీ లేదు సార్, నెట్వర్క్ స్లో ఉంది అనుకుంటా సార్.
Dr. Teja.
Ha sir, good afternoon sir.
Okay, I'm audible now?
Yes sir.
Okay, your presentation is rare case of dengue encephalopathy.
Yes sir.
Right? Okay. One, dengue, you could make out because his antibody is positive, right?
Yes sir.
Encephalopathy is made out because of symptomatology. What symptoms?
Yes sir. He presented with altered sensorium since 3 days,
yes.
sir.
So altered sensorium, you thought of
yes,
encephalopathy, right?
Yes, sir.
Commonly in dengue, we think of cerebral hemorrhage.
Yes sir. Bleeding manifestations, yes sir.
But it's not seen. On
Yes,
CT scan, what did you make out?
Sir, CT brain is normal, sir. In MRI brain, it shows T1 hypointense lesion and T2 hyperintense lesion, sir, with diffusion restriction involving the splenium of the corpus callosum, sir.
The same T1 and T2 combination is seen in neuromyelitis also. Am I right?
Yes, sir.
The same thing here again. Okay.
Yes, sir.
Right. That's why it's a tissue edema, reversible lesion.
Yes, sir. Reversible lesion, sir.
Very good. Right. So what treatment you gave him?
Sir, dengue, it is symptomatic treatment only, sir.
Only, okay.
Yes, sir.
Thank you, Amma. Thank you very much.
Okay, sir. Thank you, sir.
Then Dr. Sneha.
Good morning. Good afternoon, sir.
Rangaraya Medical College, Kakinada.
Yes, sir.
Adult onset Wilson's disease, right?
Yes, sir.
How did you suspect Wilson's disease?
The patient presented with involuntary movements involving upper limb, sir. We first ruled out the metabolic causes, sir. After that, we found KF rings, sir, but we did MRI to rule out any infarction or hemorrhage. Then we saw T2 hyperintense lesions involving the midbrain, pons, and splenium, sir. With that and KF rings, then we send a copper profile, the serum ceruloplasmin, and that confirmed the diagnosis, sir.
Ceruloplasmin is low.
Yes, sir.
Okay. Abnormally low or just marginally low?
Marginally low, sir. It was 6.26. It was abnormally low, sir. 6.26, sir. The normal range was 20 to 60, sir.
Okay. Ceruloplasmin. No,
Yes, sir.
urinary copper.
Serum
You have done that?
Yes, sir. Serum copper levels was
Urinary
89.6, sir. It was in the normal range.
Okay.
Urinary copper, 24 hours
Okay.
urinary copper was high, sir. Hello, sir. Hello, sir.
Audible, Dr.
Sir. Sir, there's no clarity, sir.
మాటల్లో వినట్లేదమ్మా?
ఇప్పుడు వినిపిస్తుంది, సార్.
ఓకే అమ్మా, రైట్. సో బిజినెస్ డిసీజ్ సస్పెక్ట్ చేశారు కేఎఫ్ రింగ్. కేఎఫ్ రింగ్ మూవ్మెంట్స్ చూసి కనబడ్డాయా? మీరు
హలో సార్, క్లారిటీ లేదు సార్.
ఓకే అమ్మా.
సార్
అమ్మా స్నేహ.
sir. వినిపిస్తుంది సార్.
ఓకే అమ్మా. ఇప్పుడు ఈ కేఫ్రింగ్లు అనేవి మామూలు క్లినికల్ గా తెలిసిపోయా లేకపోతే సిల్క్ ల్యాబ్
అవును సార్.
పంపించారా? సిల్క్ ల్యాబ్
సార్
పంపించారు.
క్లినికల్ గానే తెలిసిపోయింది సార్. మామూలు లైఫ్ తో పాటు తెలిసిపోయింది సార్.
ఓకే అమ్మా, వెరీ గుడ్, రైట్.
థ్యాంక్ యూ.
నిఖిల బ్రాహ్మణి.
Yes, sir. Good afternoon, sir.
అయ్యో పోస్టర్ on bilateral acute visual loss.
Yes,
Okay?
sir. Yes, sir.
Am I right?
Yes, sir.
Any memory deficits in this patient?
No,
Memory deficits.
no memory deficit, sir. He was conscious, coherent, and he's responding well, sir. He's answering all the questions, sir, actually. Hello, sir. Sir, I can't hear you, sir. Please. Sorry, sir.
Classically, we see.
Yes, sir. The classic
ataxia.
triad. Yes, sir. Ophthalmoplegia, global confusion, and gait
Right.
attacks. Yes, sir.
Ophthalmoplegia.
Ophthalmoplegia is
Yeah.
present in this patient, sir.
Okay, but memory disorders are not present in this patient.
Yes, sir. Memory disturbance is not present, sir. Ophthalmoplegia is present, sir.
But,
And as he's post-operative
visual
patient.
loss is unusual.
Yes, sir. The unusual presentation is visual loss, sir. Sir? Hello, sir. Sir? Yes, sir. I'm here, sir.
A tumor was removed from his right hypochondrium. Am I right?
Yes, sir.
Surgery was done. What was the tumor?
The biopsy report
Did you
was
inquire?
showing, yes, sir, adenocarcinoma, they've told, sir. Colon mass, sir.
Adenocarcinoma of colonic mass.
Colonic mass.
So
sir.
that has nothing to do with this.
No, sir. The patient was
Okay.
referred to us because of the acute visual loss, sir. And also he has episodes of hypotension, sir. Because of the autonomic dysfunction that can also be present in thiamine deficiency, sir. And that's how we suspected if there is any thiamine deficiency, sir. He's also a chronic alcoholic, but stopped consuming since 1 month, sir. And during post-operative period, the thiamine deficiency must have been aggravated, sir. That's what we thought, and we started him on thiamine, sir. And he showed some improvement, sir. Sir?
Okay, ma. Right. Thank you, ma. Thank you very much. We'll go on to the next poster. Thank you very much.
Thank you, sir.
Next, Vijay Krishna M. Dr. Vijay Krishna M.
Hello, Dr. Vijay Krishna.
Krishna.
Hello.
Hello, Dr. Vijay Krishna.
Yes, sir. I'm Dr. Vijay Krishna, sir.
Okay, Babu. Right. You're from
I'm from
Tirupati, Venkateswara Institute of Medical Sciences. Right?
Yes, sir.
Okay. Your presentation is on post-COVID neuropathy. Right?
Yes, sir.
Okay. Then can I say that this is a mononeuropathy multiplex?
Yes, sir. We can say, but mononeuropathy multiplex, it will be painful, no, sir. But in
No, need not be. Need not be. Have you ruled out a connective tissue disorder? Have you ruled out sarcoidosis?
No, sir. A patient died within 10 days, sir.
Okay, right. So post-COVID neuropathy, 2 crailers are involved, right?
Yes, sir.
Okay, a rare case.
Yes, sir.
But related to COVID, not related.
Related to COVID only, sir.
How do you know?
Yes, sir.
How do you know that is related to COVID?
Sir, a patient got discharged just 10 days back, sir. Then he admitted with again shortness of breath. On second day of admission only, he got right upper weakness, sir.
Yes, but how is it related to COVID? Is there only the history that he had COVID? Is that enough?
Sir?
Is that enough?
Nerve conduction studies also done, sir, for the patient.
Yes. What did they show?
They show axonal neuropathy is there, sir, right radial and right ulnar.
So post-COVID, there will be axonal neuropathy or demyelinating neuropathy?
Sir, maybe demyelinating will be also be there, sir.
Which is more common, demyelinating or axonal?
The demyelinating will be more common, sir.
Which occurs earlier, demyelinating or axonal?
Axonal will be occur early, sir.
Early? No. No, sir. No, sir. Demyelinating occurs early. Axonal occurs late. Huh? Okay. Right. Thank you. Thanks for a nice poster. Okay, good. Thank you.
Next, Dr. Anusha Curry.
Good afternoon, sir.
Dr. Anusha.
Good afternoon, sir.
Good afternoon, Anusha. You are from Pinnamnem Siddhartha, right? Hello.
Hello.
You are from Pinnamnem
Good
Siddhartha.
afternoon, sir. Yes, sir.
Good afternoon,
Yes, sir.
madam. Bilateral vocal cord palsy, rare complication of cortical ischemic stroke.
Cortical
Right?
ischemic stroke. Yes, sir.
Stroke involving which side? Only unilateral? Unilateral? Stroke?
Bilateral vocal cord paralysis, sir. Stroke is right hemiparesis, sir.
Okay, right hemiparesis.
Involvement of left hemisphere territories.
So left hemiparesis along with bilateral vocal cord palsy. How do you explain that?
Yes, sir.
Anatomically. Anatomically, how do you explain that? Bilateral vocal cord.
Usually in cortical. Yes, sir. Usually in cortical strokes, vocal cords are not involved, sir.
Yes.
As the vagus nerve, vagus nerve should be involved, sir, for to cause the vocal cord palsy. So there are certain studies, sir. Maybe insula may be causing the vocal cord palsy. There are certain studies. So it is a rare presentation.
Sir, here insula is involved.
Yes, sir. Insula. Yes, sir.
Okay. That's why it's a rare case. Okay, thank you.
Yes,
Thanks
sir.
for enlightening all the delegates and audience. Thank you very much.
Okay, sir. Okay. Thank you,
Thank
sir.
you, Amma.
Dr. Bhargav Chandan Sumant.
Good afternoon, sir.
From Kadapa, Bhargav Chandra.
Good afternoon, sir.
Right. Good afternoon, sir. It's Wernicke's encephalopathy, right?
Yes, sir.
So what is so special about your poster? You tell us.
Sir, the patient is 30-year-old female, 30-year-old pregnant lady, sir, presented with paraparesis, sir, with the altered sensorium for the 7 days, sir, 7 days duration. And the cause is probably the patient had severe vomiting, sir.
Hyperemesis gravidarum.
Hyperemesis gravidarum, sir. Yes, sir.
Causing Wernicke's encephalopathy.
Yes, sir.
Right?
Yes, sir.
How can hyperemesis gravidarum cause Wernicke's encephalopathy?
Sir, due to severe and prolonged vomitings, there is a depletion of the thiamine stores, sir. Losses through the vomitings and decreased intake of the nutritious food, sir.
అమ్మయ్యా సో థైమిన్ వామిటింగ్స్ లో బయటకు పోదు నాన్న అది చెప్పకూడదు ఏంటి అంతే కదా
And there is decreased appetite also, sir, to the
అవునమ్మా డైట్ తీసుకోరు ఆల్రెడీ ప్రెగ్నెంట్ కాబట్టి దిల్ బి బోర్డర్ లైన్ ఇట్ ఆల్రెడీ హ్యావ్ ఎ బోర్డర్ లైన్ స్టేటస్ ఆఫ్ డెఫిషియన్సీ దాని మూలంగా వస్తుంది తప్ప వామిటింగ్స్ లో B1 వైటమిన్ బయటికి వెళ్ళిపోదు ఏంటి ఓకే రైట్ సో హైపరెమెసిస్ కాజింగ్ ఏ వెర్నికీస్ ఎన్కెఫాలోపతి ఎలా కన్ఫర్మ్ చేసావు
sir? Serum thiamine levels were sent, sir, and MRI brain was done, sir, which showed flare hyperintensities at the bilateral caudate nuclei, dorsomedial thalamus, mammillary bodies, tectal plate, and periaqueductal gray matter, sir.
Okay, right. You said something about flare. What is flare?
Sir, it is a sort of MRI sequence, sir.
ఏంటి పూర్తిగా చెప్పు ఫ్లేర్ అంటే ఏమిటో
Fluid attenuated imaging.
Inversion ratio.
Yes, sir.
Amaya. Thank you. Thanks. Okay, log out. Thank you. Dr. Hemapriya.
Dr. Hemapriya K.
Sir, good afternoon, sir.
You are from Tirupati.
Yes, sir.
Medical
SKMC
College.
Tirupati, sir. Yes, sir.
Vanderknapp disease, rare case.
With a typical
with atypical
presentation.
Okay,
Yes, sir.
just tell me in brief what is this disease.
Sir, actually, this Vanderknapp disease is a genetic disorder, sir, where there is a problem in the brain ion and water hemostasis, sir. Mostly, patients will present in the infant age, where the infant may have this macrocephaly, and milestones may be delayed, sir. Motor milestones.
You said something about Jain families, right?
Yes, sir. Agarwal
Okay,
family, mostly
Agarwal
it is
family.
commonly seen in the Agarwal community in India, sir. But my
Okay.
patient is where consanguineous marriages are more common in Agarwal community, so there is more chances of seeing this kind of disease in them, sir. But in my patient who is neither born to a non-consanguineous mother and father, and this patient is not an Agarwal community, and this patient is presented at 14 years of age, sir. And I asked about their birth history and during infant about the development of milestones. Everything was normal only, sir. This patient presented only with GCTS type of seizure, sir. That too only one episode, post-ictal confusion lasting for 1 hour. And we started investigating based upon simple random sugar and electrolytes, and then a patient was actually not affordable for EEG, sir. So we sent a CT and MRI is available in our government hospital. We sent for CT, sir. It showed query vasogenic edema. There also hyperintensities or hyperdensities are present in the white matter, so frontoparietal white matter. So, and they asked us to send for MRI too. And then we send MRI, sir. In that MRI, it showed hyperintensities in the periventricular frontoparietal and anterior temporal lobe, sir, with subcortical U fiber involvement, which is the pathognomic feature, which is the hallmark for this Vanderknapp disease, sir.
Prognosis?
So prognosis, it depends. In Vanderknapp disease also, there are many genotypes, sir, like MLC1, MLC2, MLC2A, 2B, like that. Depending upon the type of involvement, patient prognosis differs, sir. My patient, actually genetic workup is not done as patient is not affordable. But just depending upon the normal birth history and the normal childhood and only seizure presentation, that too at 14 years of age, so it is we can fit this in MLC2B, sir.
Okay, madam, thank you very much. You got a good future. Thank you.
Thank you, sir. Thank you so much, sir.
Dr. Jagreeshwar Reddy.
Sir, good evening, sir.
Okay, you are from Narayana Medical College, Nellore. And
Yes, sir.
diabetic amyotrophy, a rare cause of muscle weakness. Okay, good. Why do you say it is rare? What is the actual incidence in diabetes? Even in diabetics.
Yes, sir.
Incidence
diabetes,
is-
but it's incidence very low, sir. Less than 1%, sir.
Okay.
Hello.
Right. So, is it painful or not painful?
Painful, sir. Painful and asymmetrical muscle weakness will be seen, sir.
Proximal mostly. Can also
Proximal muscle weakness.
distal also can get involved.
Yes, sir.
Why did you suspect a diabetic amyotrophy? You could have gone for some other reason.
Yes, sir. This is a diagnosis of exclusion, sir. All other proximal myopathies are being excluded, sir.
Yes. Very good. Diagnosis of
So-
exclusion. Because it's
Yes,
a
sir.
rare condition. Even diabetes is rare. It's rare. We see so many diabetics. Most often we see a symmetrical sensory, rarely
Sensory.
motor neuropathy. But and then ophthalmoplegias. But not this type of amyotrophy, a rare condition in even diabetics. Non-diabetics, even more rare. Exclude all other causes before saying that it's diabetic amyotrophy. Right?
Yes, sir.
Okay.
Yes, sir.
Only physiotherapy and diabetic control. That's all. Okay.
Yes, sir.
Thank you. Thank you very much.
Thank you, sir.
Sir, next, see Sandeep.
Mr. Murthy.
Sir,
from 41, some other.
Only Raghunath undi, but Raghunath
41. Sir, చెప్పండి sir.
సురేష్ ఇంకా హర్ష తో అదే కిమ్స్ అండి.
Sir, చెప్పండి sir.
I mean, from I said from 1 to 40, I will do it. From 41 to 50 is some other batch, by some other team of evaluators.
Only 4 are there, sir. Only 44 are there with us.
Okay, so 4 more. Okay.
4 more.
Can I
end
the session?
They are in this meeting only.
They are in this meeting only. Yes, sir.
Okay, all right. Okay, go ahead.
Sandeep.
Afternoon, sir.
Rare association of autoimmune polyglandular syndrome with FAR syndrome. What is FAR syndrome?
Sir, FAR syndrome, it is an abnormal calcification in the brain, sir, due to abnormal vascular calcium deposition, sir. Calcifications are mainly seen in basal ganglia, cerebellar dentate nuclei, and white matter, sir. It's subsequently lead to atrophy, sir.
How about the polyglandular syndrome?
Sir,
polyglandular dysfunction, autoimmune disorder, right?
Sir, autoimmune polyglandular syndrome, it has mainly 3 types, sir. Here the patient had type 1, sir. Type 1 has a syndrome of 3 conditions. It has candidiasis, hypoparathyroidism, and adrenal failure, sir. Patient has this hypoparathyroidism is leading to calcification in the brain, sir.
Yes. Okay. So rare case. How could you confirm you got the parathormone assay done?
Yes, sir, done, sir.
Okay.
I have parathormone
got an
MRI
you
done,
got
sir.
an MRI done. Okay, right.
Yes, sir.
So based on that, you made a diagnosis.
Yes, the patient had low
Clinical
parathyroid
presentation.
level.
Clinical presentation. Is it?
So clinical presentation, actually patient presented with Bell's palsy, sir. Bell's palsy. So we did an MRI, sir. In the MRI, the patient had multiple calcifications, sir. In the retrospectively, patient had also had an recurrent candidal infections and
అంటే నీతి ఏమిటి అంటే బెల్స్ పాల్సీకి ప్రతి బెల్స్ పాల్సీకి ఎంఆర్ఐ చేయమంటావు.
అంటే పేషెంట్
okay. I'm not making fun of you. That's nothing more than that. ఏం సరదాగా తీసుకో. ఏమ్మా బెల్స్ పాల్సీ ఉంది, హిస్టరీలో రికరెంట్ క్యాండిల్ ఇన్ఫెక్షన్స్ ఉన్నాయంటున్నావు కదా.
Recurrent candidal infections. Along with that, patient at the time of admission, also patient had blood pressure also 90/60, sir, which is somewhat low, sir. And I had patient had Johnstock signs also, sir.
Okay, ma, right. Thank you very much.
Sir.
Thank you. Log out. Kavya.
Next, Kavya, Sri Kavya.
Sir, good evening, sir.
Good evening, Kavya. You are from Narayana Medical College, Nellore. And
Yes, sir.
dorsolateral tegmental syndrome, right?
Yes, sir.
Rare clinical
Hello,
type
sir.
of primary
Hello, sir. Sir, your voice is breaking, sir. Hello, sir. Sir? Sorry, sir.
Amma, wait for
Hello?
the technical people to correct.
Okay, sir. So now it is fine, I think, sir.
Okay, Amma, right. My voice is audible?
Yes, sir, you're audible, sir.
Okay, Amma. Primary pontine hemorrhage, dorsolateral tegmental syndrome, right? What is
Yes,
the
sir.
clinical presentation? Which nerves
So,
are parallel? Cheppama.
So initially, the patient presented in the unconscious state, sir. On examination, her BP was very high, sir, 180/110, sir. And she regained consciousness the second day, sir. Then she had difficulty difficulty in walking, sir, because of imbalance. And she also had on examination, she had a loss of corneal reflex, sir. She had lateral gaze palsy, and she had element type of facial nerve palsy, sir. And she had some slurring of speech, sir. Since this gives us idea about the involvement of 5th, 6th, 7th nerves, which could be localized to pons, sir. That too on the dorsal aspect of the pons, sir.
Because cerebellum is involved. Ataxia. cerebellum is involved?
Yes, sir.
Okay.
Yes, sir. Yes, sir.
Hmm.
Yes, sir. So
So
we localized
dorsal.
it to the dorsal pons and yes, sir.
Okay.
But she doesn't have any weakness, sir. No motor weakness, sir.
Okay.
Hello, sir.
Right. So something like something because brainstem vascular syndromes, right?
Yes, sir.
Inferior medullary, superior medullary, medial
Yes, sir.
medullary. Like that,
Yes, sir.
in the pontine also, there are 3 levels: superior pontine, mid pontine, inferior pontine level, brainstem vascular syndromes. There are
Yes,
3
sir.
varieties.
Yes, sir.
So out of these 3, this fits in. Okay. Right, madam. Thank you. Thank you very much.
Thank you, sir.
Thank you very
Next,
much, madam. Okay.
Venkata Sai Krishna Reddy.
Sir, good afternoon, sir.
You are from Vijayawada, Siddhartha Medical College, right?
Yes, sir. Yes, sir. Yes, sir. Am I audible, sir? Hello? Hello?
Hello.
Sir, am I audible, sir? You are
Rare
not
case,
audible
sir.
to me, sir.
Okay, whatever you say is okay for me. Excellently audible.
Sir, your voice
Okay,
is slightly breaking,
now
sir.
it's better.
Yes, sir.
Okay, right. Try to understand. Does he have any history of alcoholism?
Yes, sir. He was consuming alcohol since the age of 15, sir.
So can
But
alcoholism
we could
might
not,
have
we
caused
could,
this?
sir.
Can
But we
is
did.
alcoholism reason for this?
Yes, sir.
For
No, not
MPD.
only alcohol, sir. Nutritional deficiency is the cause, sir.
Okay, okay. And how about this benzodiazepine poisoning?
Sir, actually, he was out of his home, sir. But later he was brought in unconscious state, sir. His parents found empty packet of alprazolam tablets in him, sir. So he might have consumed. He kept his addiction secret,
Might
sir.
have.
Yes, sir.
Okay. So that's we can take that out. Basically, it is because of alcoholism presenting as morphia disease, right?
Yes, sir. Yes, sir.
Okay. Clinically, unconsciousness.
Yes, sir.
Anything else clinically?
Clinically, at the time of admission, he was unconscious, sir. But after we supplemented thiamine, he gained consciousness and he developed mild ptosis in the right eye, sir. Actually, after yes, sir, only ptosis was there, sir. No nystagmus was there, sir. Tremors, nothing were there, sir. But by the time of after we gave thiamine for 5 days and methylprednisolone, about 15 days later, he developed power 5/5, sir. Then he developed slight resting tremor, sir.
Okay. And MRI showed a corpus callosal lesion, cystic
Yes, sir.
lesions.
Yes, sir. Yes, sir.
Okay. So it's diagnosed based on MRI, right?
Sir?
Because up till then it's only let's say Vedikis, alcoholism, unconsciousness, tremulousness.
Yes.
So
There
until
is no
MRI is taken, it's only Vedikis, unusual, atypical Vedikis.
Yes,
Okay?
sir. Yes, sir. Yes, sir.
Only after MRI you made it as a morphia.
No, sir. Actually, first we did CT scan, sir. They showed mild hyperdensity, sir.
So initially itself you have gone for okay, right. Thank you. Thanks for a nice presentation. Thank you.
Thank you, sir.
Dr. Ashwati.
Ashwati.
Yes, sir. Good morning.
Madam,
Good afternoon,
you are
sir.
from good afternoon, SMC Vijayawada.
Yes, sir.
Ehlers-Danlos syndrome.
Yes, sir. Yes, sir.
Sarcoidosis.
Yes, sir.
Okay. Lymphadenopathy, parotid enlargement.
Yes, sir. The patient actually presented in the casualty with proximal lower limb weakness and by this drooling of saliva and deviation of mouth. And so initially we thought that as GVS syndrome, sir. So we did this NC's nerve conduction studies the next day, and it came as mononeuritis multiplex. And the routine evaluation also, that showed that chest X-ray that showed hilar lymphadenopathy. Sir.
Good, fantastic.
Hilar lymphadenopathy. So thereafter, in routine evaluation, calcium also was seen as elevated. Then we retrospectively inquired about the thing. Then we noticed a parotid enlargement, sir, which we initially didn't notice that much. So then later, the parotid enlargement, he complained of on and off fever and all, sir. And since the NCS study showed mononeuritis multiplex, we scanned for another vasculitis and also this connective tissue disorder. Also, screening was done. That all turned to be negative, sir. And we went for CSF, and in CSF it showed albinocytological dissociation, which can also be seen in sarcoid and also in viral encephalitis, HIV and all. But the viral markers were all negative. And we went for CSF AC levels, which were shown as positive and elevated, and serum AC levels were also elevated, sir.
Okay,
And later for a histological diagnosis, we sent for FNAC parotids also, sir. That also came as non-caseating granulomas, sir.
So basically, calcium should get serum calcium and ACE levels. That's all, right? Apart from X-ray showing a hilar lymphadenopathy.
Yes,
right?
Yes.
Okay, Amma. Thank you. Thanks for bringing us a nice case as a poster.
Thank you so much. Thank you.
సార్ సార్ మనం ముందు ఒక 4 రోజులే అంటే లైక్ వాళ్ళు రాలేదు సార్, ఇప్పుడు ఉన్నారు వాళ్ళు, డాక్టర్ లింగప్ప.
ఓకే, నంబర్
సీరియల్ నంబర్ 18 సార్.
18.
డాక్టర్ బి లింగప్ప.
ఎస్ సార్. హలో సార్.
హలో డాక్టర్ లింగప్ప గారు.
సార్ గుడ్ ఆఫ్టర్నూన్ సార్.
గుడ్ ఆఫ్టర్నూన్. యు ఆర్ ఫ్రమ్ which college?
సార్ ఐ యామ్ ఫ్రమ్ కర్నూల్ మెడికల్ కాలేజ్.
Rare case of
anti-MOG associated encephalomyelitis.
Okay. Yes, what exactly is this MOG antibody?
Sir, it is a myelin oligodendrocyte glycoprotein, sir. Antibodies against the myelin oligodendrocyte glycoproteins. So it is present in the
what is the common clinical presentation?
Common clinical presentation is quadriparesis with bilateral loss of vision, sir, with optic neuritis. Quadriparesis due to the longitudinal extension of the spinal lesion. Cervical spine lesion.
Cervical spine lesion. Okay.
More than 3 segments are involved, sir.
Okay.
It is a differentiating, sir. It is a differentiating feature from the multiple sclerosis.
Multiple sclerosis or neuromyelitis optica-like syndromes?
It is a neuromyelitis optica-like syndrome. Optica syndrome.
Okay. No, it's related to that only, right?
Yes.
Okay. Right.
Thanks.
Rare case. Patient survived or did not survive?
Sir, patient survived, sir. Initially, we started with glucocorticoids, sir. Initially, power was improved from 0 to 2, sir. After that, we put oral steroids with along with immunomodulator drugs.
He's okay
After
now.
discharge, the patient not came for follow-up, sir.
Okay, ma. Right. Thank you. Thank you for picking us a rare case. Thank you.
Thank you, sir.
Murthy garu unkollu.
సార్ పద్మరాజు శశికుమార్ రాజు.
Yes. డాక్టర్ శశికుమార్ రాజు గారు.
శశికుమార్ రాజు గారు లేరేమో సార్. ఓకే, పొన్నాడు సాగర్. డాక్టర్ పొన్నాడు సాగర్.
సరే సార్.
Hello sir. Yes, your doctor.
Serial number 26, sir.
Okay, okay.
Sir, good afternoon, sir.
Good afternoon. Paraplegia caused by superior sagittal sinus thrombosis.
Yes, sir.
Right. Okay. Did you? Okay. So probably the patient.
Sir? Hello, sir. Hello, sir. Sir.
Sorry. Patient.
Sir, voice is not clear, sir.
Okay, we'll wait. We'll wait. The clears up. Patient presented with headache.
Hello, sir.
Hello.
Sir. సార్ ఎస్ సార్ వినిపిస్తుంది.
వినబడుతోందమ్మా?
సార్ వినిపిస్తుంది.
పేషెంట్ ముందు హెడేక్,
ఎస్ సార్,
ఆల్టర్డ్ సెన్సరీ, వామిటింగ్స్ వచ్చారా?
ఎస్ సార్. Along with 1 day history
కన్వర్షన్స్ కూడా ఉన్నాయా?
Yes sir, with 2 episodes of generalized tonic-clonic type of seizure sir.
Convulsion.
Yes sir.
Okay, you got a CT done.
Yes sir, initially CT done sir. Yes sir. Hypertension and vertigo sir.
Hypercoagulable states అలా కదమ్మా, హైపర్కోయాగులబుల్ స్టేట్స్ కోసం ఎవాల్యుయేట్ చేసేవా?
Yes sir, protein C, protein S, antithrombin, yes sir, all are normal sir.
All are normal.
Yes
okay. మరి రీజన్ ఏమైంటుందంటావు?
Sir, patient had history of chronic alcohol intake sir since one week without any intake of food or so alcohol related any dehydration causes. Yes sir.
Okay ma, right.
So, sir,
right babu, thank you for bringing us this post sir.
Sir, thank you
okay,
sir.
Ma.
Next sir, next Sai Baba, last
one sir. Number
yes,
abstract number చెప్పగలరా?
sir 29 sir, serial number
29.
Sai Baba garu, Dr. Sai Baba, please come online. He is there. Dr. Sai Baba, please unmute yourself sir. Dr. Sai Baba garu.
Okay. Hello.
ఇచ్చాడా? డాక్టర్ సాయిబాబా నెక్స్ట్ టైం వచ్చే మనకి ఇవేనా 44
డాక్టర్ సాయిబాబా. సార్ మనం 44 లో ఓన్లీ లైక్ అంటే ఇప్పుడు ఎవరు పద్మరాజు శశికుమార్ రాజు ఒక రాలేదు సార్ మనకి.
ఓకే, లీవ్ హిమ్ అవుట్.
వాళ్ళ ఓకే, ఆయన ఫోన్ కూడా కనెక్ట్ అవ్వట్లేదు. సాయిబాబా గారు ఇప్పుడు ఆల్రెడీ ఉన్నా అన్నారు.
క్లోజ్ చేసేయండి మూర్తి గారు.
క్లోజ్ చేసేస్తామా?
మీటింగ్ క్లోజ్ చేసి